Thank you, sir. My topic is follow-up of early lung cancer post-treatment. So this is divided into two parts: how frequent and what modalities to be used during the follow-up, and what are the chronic complications and how to tackle them. So basically, what we are covering is this is not intended for patients who are on active treatment, not intended for patients who are diagnosed to have advanced lung cancer, and follow-up of imaging only if individual is fit or willing for further oncological treatment in case of recurrence is detected. Why is the rationale for imaging in the follow-up? Because the recurrence is as common. We know the survival is not that good. 25% of people, even early stage, die in first 5 years. That's why surveillance is recommended. Rationale here is to detect recurrent disease. That's why we get additional time for planning of further treatment. To detect a second primary lung cancer, other smoking-related malignancy can be also be detected. Intervention can increase survival and might offer curative retreatment and or improve quality of life. Data from phase 3 randomized trials are yet not available to clarify surveillance recommendations. Therefore, the most appropriate schedules are still controversial. So I have taken some of the these guidelines from ATS, some from NCN, and some from ESMO. So what the first statement here is that patient should undergo surveillance imaging for recurrence every 6 months for first 2 years. Patient should undergo surveillance imaging for detection of new primary lung cancers annually after the first 2 years. So first 2 years, every 6 months, and after that, once in a year. Clinician should use a diagnostic CT that includes the adrenals also with contrast preferably or without contrast when conducting surveillance for recurrence during the first 2 years of post-treatment. Clinician should use low-dose screening CT chest when conducting surveillance for new lung primaries after the first 2 year post-treatment. Clinicians should not use FDG PET CT as a surveillance tool. Why so is that after 2 years, the goal of surveillance switches from detection of recurrence to detecting of the new second primary. And CCT yields greater accuracy and reduce inter-reader variability in the detection of enlarged hilar nodes in comparison with unenhanced CT. And recognition of mediastinal node is same in the both cases. One of the studies had performed where they compared 92 patients post-resection where they had done 18 FDG PET CT with standard CT, bone scintigraphy and brain MRI at 6 months interval post-resection. No improvement in sensitivity or specificity was found. The radiation exposure with FDG PET CT was higher at 32 millisievert as compared to 3 to 7 with diagnostic CT, which was also high as compared to low-dose CT, which was only 2 millisievert. Also, there is higher cost of PET CT as compared to diagnostic CT, and this is almost equivalent to low-dose CT. And there are also issues about positive predictive value and negative predictive value of PET CT in the Indian population. Now, recently, we had a Lancet publication. This is the first randomized controlled trial where CT chest plus chest X-ray as compared to CT was followed up in resected lung cancer patient. It was a multi-centric trial, open label, and here patients who were 18 years or more were included post-resection from early stage lung cancer group, and it was done across 122 hospitals across the France. Patient was randomized into 1:1 into CT-based follow-up versus clinical follow-up plus chest X-ray, and this was repeated every 6 months for first 2 years and then annually until 5 years. The primary endpoint was overall survival analysis in intention to included population. Secondary endpoint included DFS. So result this from trial was that there was no difference in median survival in both the arms. Even if CT was done or chest X-ray done on the follow-up, there was no difference in median overall survival. DFS was also not significantly different between the two groups. Recurrence was detected more often in patient undergoing CT, and the curative treatment was also more offered. But despite that, OS did not differ, and no serious adverse events were related to trial procedure were reported in the CT arm. So, what they had concluded that more longer follow-up is required for this trial so as to not potentially miss the long-term OS benefit from CT-based surveillance. But as of now, there is no OS difference between both the arms. So this is a snapshot from NCCN. Here also they have recommended same for first 2 years, 6 monthly to 3 CT scan and then annually, and thereafter low dose. PET CT or routine brain MRI imaging is not recommended. Although FDG PET is used only when there is some confusion in the post-operative setting or post-edition setting to differentiate between atelectasis or residual disease, because sometimes the post-edition FDG viability can be there up to 2 years. If there is FDG residual activity is found in the PET CT, we need to rebiopsy it to confirm there is persistent tumor or it is just post-edition activity. So, surveillance imaging can be omitted in patients who are clinically unsuitable or unwilling for further treatment. Age should not preclude surveillance imaging. Consideration of overall health status, chronic medical condition and patient preference is recommended. For example, due to clinical instability, patient preference and values. For example, 90 years, if he is not going to take any further treatment, there is no point in doing further surveillance actively. Clinicians should not use circulating biomarker as a surveillance strategy for detection of recurrence in patients who have undergone curative intent treatment for stage 1, 2, 3 or for small cell lung cancer. CE post-treatment increase in follow-up in stage 1 was found to be associated with poor prognosis in some studies. However, no data for survival improvement or higher rates of false positivity are found due to COPD and smoking. So, generally CE is also not recommended. Circulating free DNA, it was found that it rises 2 to 5 months average before any radiological changes are there. But as of now, it is not recommended in routine clinical setting. It is recommended only in trial setting. For patients of stage 1 to 3, routine MRI of brain, as I told before, is not recommended. But patient from small cell lung cancer who had received PCI or not PCI, every 6 months MRI brain, 3 to 6 months is recommended depending upon the clinical condition of the patient. This is a snapshot of ESMO and NCCN recommendation. More or less they are same. But what I want to highlight is PET is not routinely recommended and MRI is not routinely recommended. Now coming to the second part, chronic complication and late effects. So there are a lot of sequelae of surgery, radiation, chemotherapy and now immunotherapy as well as the TKI. There are a lot of psycho-socio-economic aspect of treatment and follow-up. So 80% of patients have some physical symptoms on follow-up and 30% of them have clinically significant symptom. Fatigue is most common post-surgical symptom reported by lung cancer survivors, and up to 90% of patients report this symptom. And lobotomies have been associated with significant decline in sleep, mental function, sexual activity, overall health-related quality of life, and even years post-resection. Psychological distress can be found up to 80% of lung cancer survivors. 3 times more common it is observed in survivors of lung cancer as compared to other cancers. Then other symptoms of generalized fear, specific fear for recurrence, sadness, worry, uncertainty, stress, relationship stress, poor sleep quality, lack of concentration, depression, anxiety, suicidal ideation, and survival guilt is found. Clinicians should treating this patient should be aware of routine screening procedures like for depression, PHQ, anxiety, GAD, and psychological distress. We use screening method as distress thermometer. Cognitive impairment is found in half of the cancer survivor patients, and it can persist up to decades and significant. It impacts the quality of life significantly. Subjective difficulties can occur like difficulties with attention, concentration, and short-term memory loss. Sexual dysfunction is often overlooked in this patient. 60% of patients report some long-term sexual dysfunction, but however, only 25% of these patients seek some help. Shortness of breath, fatigue, emotional distress have been indicated as contributing factors. They report problems with sexual desire, erectile dysfunction, orgasm, frequency of sexual activity, body image, and communication about sex. Then, as we know, some of these patients continue to persist using tobacco, and after surgical resection with curative intent, second tumors are 2.3 times more common with this patient, and recurrent tumor occur in 1.9 times more in patients who continue to smoke. Overall mortality also increases in patients who continue to smoke, that is around approximately 3 times. There are differences pharmacokinetic and dynamics of these patients who continue to smoke. Due to shortness, I'll just skip, and what I want to highlight is vaccination, which is often overlooked, and there is decrease in incidence of immunorecognition in this patient, and the dose of vaccination might be higher in this patient. We need to have some studies of this. There are other issues which I could not include, that is challenges to family life, challenges to the caregivers, coordination of care between the primary doctor and the tertiary doctor who is treating the cancer, and challenges for vocational rehabilitation of these patients. This is the list of the vaccination which is recommended: annual influenza vaccine, herpes zoster vaccine, pneumococcal vaccine, and COVID vaccination, and hepatitis B vaccination also. So take home messages are: routine MRI scans, except in case of small cell lung cancer, circulating DNA and PET CT is not recommended. Aggressive imaging and follow-up is yet to show any benefit in terms of survival. Quality of life, symptomatic care, rehabilitation, and vaccination should be prioritized and should not be overlooked in overzealous pursuit to investigate the recurrence. Thank you.